So 11 days post-op double jaw surgery to treat my sleep apnea with Dr. Sam Bobek at Seattle Jaw Surgery. This video is the conversation that Dr. Sam Bobek and I had just a few days before my actual surgery. Nothing was prepared. It was just a standard telemedicine pre-op appointment. And I asked him at the very beginning if he'd be okay if I recorded things, to which he said he had no problem. So here's the raw footage. I hope you guys find some value there. If you have any questions, just let me know. Enjoy.
But getting back to the two-dimensional x-ray, like that Ceph business, right? So this is the order of magnitude of movement. My understanding is you're okay showing a little bit less gum when you smile. Is that correct?
Yeah, so what does that mean? I understand obviously what it means, but like, what's the implication there? Is it more aesthetically appealing to do that, or a little bit less? Is that why you're kind of bringing it up, or what does it translate to in layman's terms?
So the movement of the bones of the face are in three dimensions. I have you impacting a little bit, so you're shortening. In terms of airway, shorter airway, wider, more forward tends to be the dimensions we want to create. But there's too short, too wide, too forward. You know what I mean? And so I think functionally the benefits of the upper jaw moving up a little bit, because right now I have it 3.5, moving it up a little bit is better contact in back. So with counterclockwise rotation, this part moves down. And so a little bit better contact. This allows me to harvest bone here, which I'll show you in a minute how that works.
That's like the floor
Uh,
of the nose shaving thing.
yeah.
And most of you guys are doing that now, right? In the Vanguard, it kind of helps with breathing or something. Or why do you do that? Sorry, I'm all over the place.
Um,
I'll let you. I'll
oh
let you.
yeah, no problem. So one of the reasons I started actually the whole podcast thing was just kind of standardize some of the things we were talking about. But there's a subspinal osteotomy. That's usually how that's done these days. I generally like doing that, by the way. So, in your scenario, what that does is it minimizes tip rotation. Um,
Oh, so I
so
don't look like a pig or whatever. Kind
yeah,
of.
exactly. So in the simulation, you see how the red nose, you see how the tip of the nose is turning up.
Yeah.
This gray is where your nose is, the reds with that. I didn't account for that in the simulation, so I wanted to show you it. The nose tip change is generally a negative thing. You see how it wants to rotate up?
Yeah. Yeah.
And if we actually kept the anterior nasal spine attached, you can kind of see why that happens. I think it actually can happen a little bit more than that. Um, so what actually happens with the surgery is not 100% what's shown here, which is the subspinal or the subnasal osteotomy. But then in addition to that, there's this harvesting of bone. So this harvesting of bone, I can recycle it. I can recycle it here. I can recycle it here. I generally use that bone for seeding cadaver bone with your bone cells. But I think it's also functionally helpful for breathing. And you have a kind of nose that would like that. So a lot of times people think of the upper jaw going up and they think their nose will have less space, but because that bone is harvested, that isn't the case. So let me to show you a different way. This is if I make your planned translucent movements to where you are now. Do you see your nasal base here?
Where is that exactly?
Right here.
Okay, yeah, yeah. That's the floor of the nose, right?
Floor of the nose,
Yeah, yeah.
front part of the floor of the nose, a little bit of asymmetry to it. But as we bring into the new movement, if we didn't adjust for that bone, then you would have less space. And a millimeter less than the floor of the nose is a lot, actually,
Yeah.
because there isn't a big passageway for air to go. And so I'm much more in the camp of reducing the bony interference than I am messing with your turbinates or something like that. So anyway, impaction of the teeth is an aesthetic variable when it comes to that. And as the upper jaw moves forward, because this is an 11 millimeter movement, I would expect you to show a few extra millimeters of movement. So, or millimeters of teeth, I'm sorry, I said. And that just has to do with as the upper jaw moves forward, the lip rotates up, right? So if we didn't move you up at all, you would show more gum.
I see. So it's like adjusting together sort of thing.
Yeah. So I think a 3.5 is on the side of you'll show a little bit less gum, but not much less. And one of the reasons I think we touched on it that I don't necessarily love custom hardware, is that I want to be able to adjust that in real time. And so probably one of the bigger variances from the final result to the planned result is the fact that I have a 3.5 millimeter plan, but I look at you during surgery and you need to go up a little bit more. So we plan 4.5 or 5. Um, and so if that happens, by the way, so if that occurs, what will generally happen, not generally, but what will happen is that the overall thing will move forward a little bit because surgery, because lower jaw surgery happens first, the way adjusting the vertical by impacting it a little bit more, how that impacts the final result is that everything moves forward a little bit more. Does that make sense?
Yeah, it does. It's like it sounds like you have to do that sort of to accommodate the counterclockwise rotation as well. Is that fair to say or not really? Am
You
I?
end up with a little bit more counterclockwise. It just the response of the upper lip to the upper jaw moving forward is different depending on the person. So people with thinner soft tissues or thicker soft tissues, gender preferences, generally women want to have a little bit more gum show. Guys are fine with less gum show. And so where we plan on things depends on the individual. But then there's also the response to the plan because the estimate on where the lip ends up is
Okay.
just that, it's an estimate. So 3 to 1, like 3 millimeter advancement shows 1 more millimeter a tooth isn't true for everybody. Some people are 2 to 1, some people are 4 to 1. And so I like planning you to where I think this will be about the right plan, or you're a little long, because in your situation, I think the error is not moving you far enough forward. So, because I mean, you're doing this to breathe better. And so remember the error bar when it comes to these things is it tends to be on the shy side. So if we're planning, let's say 11 millimeters in the maxilla, the error bar tends to be 9 to 11. Pagonion is, let's say 14, 15. The error bar is more like 13 to 15, right? Um, and so the only thing that pushes us on the other side is we do impact a little bit forward. So leaving things a little lower is fine. But if like one of your aesthetic goals was to show less gum when you smile, I'd probably impact you a little bit more than what we have planned right now. Did you have that as an aesthetic goal or not really?
Not really. I don't understand that stuff like too in detail. Like
Yeah, I
how
mean,
X, looks compared to Y necessarily. There's some stuff I understand a little bit better, I would say, but I trust you with what
um,
you're saying. I mean, I
well,
feel
there's
comfortable.
yeah, I mean the gum show because it partly has to do with the vertical position of things, but
I
also
th
has to do
I
with
think
like
I
your
get
lip
it. Like
mobility.
if you just advance the maxilla, naturally the lip will drape higher and higher, right? So you're kind
Yeah,
of
exactly.
moving it a little bit so that it looks kind of how it looks now, kind of.
Yeah, yeah. From a general way, I think that's totally right. So there's these face height ratios. Anyway, we're shortening you a little bit when it comes to that, so I don't want to overcomplicate it. Um, which I think is a good thing. So from the magnitude of movement, it's very much like we talked about. So the other variable that we can play with here is the amount of counterclockwise rotation. So this one's a little bit strange, but this is the way it is. So looking at this right side of the image here, this shows you from a frontal plane what counterclockwise rotation does. And so right now, I have you in a good balance of aesthetic, but you could tolerate more counterclockwise. So if we change this more, so on the extreme, by the way, so we're not going to do this, but do you see how the skeleton turns frowny and then it turns smiley? I know that sounds silly, but it's like we're making a skeleton. I feel like I'm playing with anyway,
Yeah, I see that.
doing like
Yeah.
a dollar bill trick or something here. It's not like that, but by changing the occlusal plane. So counterclockwise rotation has a trend to widen the lower face. So it tends to make this wider and proportionately too much lower jaw, whereas the opposite is true with clockwise rotation, right?
Right.
So clockwise, it turns you more into a smiley skeleton and it's out of proportion. And so on the plan that we have in front of us here, which is kind of the most straightforward one, I think you could tolerate a little bit more counterclockwise rotation. I don't think there's anything wrong in that. It's just that it starts flattening out your smile a little bit. Most guys don't care about that. But I do want you to know. So without that extra change, it's about 4 degrees counterclockwise.
That's the more conservative number you're saying?
Yeah. And I don't think there's anything wrong with this in terms of the overall picture. And this is more like 7 degrees or something of that nature. So a little bit more counterclockwise. The numbers of where your upper teeth should be and where your smile should be are the main things that get affected with that. This makes your chin more in proportion with everything, by the way. So
How obvious of a difference is that difference in degrees, would you say? If I was smiling to someone who never met me,
they
and
wouldn't notice it.
they wouldn't notice it.
No, I pick up on it. I have to remind myself that I'm my eyes too good on these sort of things, and I lose sight of what's normal. And so, truly, what is the issue is this area of your smile. You start seeing more of this stuff. Like you start seeing more gum and back when you smile.
With more
And
counterclockwise.
yeah, with more counterclockwise. And so it's just hard to show on the soft tissue simulator because you aren't smiling, but I think you can believe it. The teeth should follow the curve of the lip when it comes to smile aesthetics. So like the curve of the lower lip should match the teeth. And when we do a little bit over counterclockwise, you just see a little gum back here. Not the end of the world, but I think it's a reasonable aesthetic trade-off in the overall picture by leaving you a little bit flat.
And
Because
the
guys,
idea to do that is not aesthetics, but it's obviously a functional benefit by like further counterclockwising, right?
yeah, like getting more advancement at the chin.
Yeah.
So,
Okay.
I mean, you're not egregious. Everything's still in balance. Like you're still skeletal class one. The chin position is still reasonable. So I think counterclockwise and you a little bit extra would be my preference. Um,
Plus, I'm getting
this,
married, so we can sacrifice the looks, right? She's locking in, so.
that's right. You should almost get her signed up ahead of time. I guess she is already. The way the teeth fit. So the upper jaw expansion did a good job on that. I cheated a few things on this one. So if you notice the midline's a little bit different. They're a little bit offset, and that has to do with just the rest of the teeth, how they line up. I don't think there's functionally much concern in that aspect. If you look up the upper jaw is wide in relation to the lower teeth. Um, Generally the contact is good. It's just I don't necessarily like grinding on teeth much, and so I was um, this is within Invisalign type finishing approach on the teeth. As we fly around, there's these wisdom teeth on the bottom. Did you want me to take those out, or do you want me to leave them? I don't care either way, actually.
Um, what's the best thing to do?
Um, they won't impact at all on the airway. They're not going to be functional anymore. So right now, the way your teeth fit, because you have a little bit of an underbite, that goes away. So those teeth won't be functional. Um, um, we can play it by ear. I'm fine with that. I can do surgery with leaving them in place. Sometimes people like holding onto their wisdom teeth. I'm not sure why, but it won't impact the surgery either way. So
Okay.
um, I think leaving them in place can simplify it. So
Okay.
yeah,
I could always take them out later too, right?
exactly. Yeah. When it comes to the wisdom teeth, it would just be, it doesn't change your recovery. There is a chance of dry socket, but it's small.
It doesn't help like removing them doesn't help you get a cleaner cut with the BSSO or anything.
No. Yeah, there are times, and it's your teeth don't look like this. There are times that the wisdom teeth are going to be in the way of the cut, and so everyone's got a little bit different thickness. Your teeth are away from where I'm doing surgery, so there'll be bone in between the areas. I expect to not see your wisdom tooth actually. So if during surgery there's an injury to it, I can take it out. So I'll get the consent for it. But the way things line up, I would prefer just kind of leaving them in place, I think. So if you don't have a strong preference, leaving them there should be fine.
Yeah.
The lower jaw, so making the lower jaw translucent, I think is useful information here. So if you remember from a wrist situation, there's this nerve risk, right? So there's this nerve that lives in a canal. And so the canal sits, sorry, my drawing is not the best, but the canal sits in the middle of your angle. This is, as we take away the upper jaw, these are the canals. So I don't know if you can see that round area
Right, yeah.
that enters the bone, same sort of thing here. So that round area has a nerve that gives feeling to the teeth and the gums, and it exits up here by the chin. And so where that nerve sits inside bone, you can see when the lower jaw is advanced with counterclockwise rotation. You'll notice at the Dalpont how it isn't advancing as far as the chin, by the way. So I don't know if I'm skipping around a little bit, but just as a heads up, those tend to be different. But the nerve trouble isn't that it gets cut or torn, it's that it gets pinched. And so that's best appreciated from below. And so from below, you will see that as the lower jaw moves forward, the blue segment bumps into the yellow segment. And it's the mechanism that pushes it wider. And that is usually because of these bones interfering as they advance. So as the lower jaw advances. And so during surgery, I don't want your nerve to be pinched. And so I will remove bone, most commonly in this area on the backside here. So on the blue segment in that area to give your nerve home. And so that's helpful, I think, for nerve healing. I want your nerve to recover. Most people very numb when you wake up. Next day, you're still very numb, and it takes weeks or months for that to come back. Long-term risk is that it's doesn't wake up all the way, so you have partial. So whether that's 20, 50, 80% return is one of the reasons I want to see again at 6 months. Also want to see how you're doing with sleep. But the neurosensory recovery, I think making room for the nerve makes a big impact. The trouble with making room for the nerve is that it takes away bone overlap. So it's good for nerve healing, can be bad for bone healing. And so there's a plate that holds the lower jaw in place. But a lot of times when you have an advancement and I need to remove some bone for the nerve, I end up putting an extra screw up on top. And it's usually one, but sometimes it's two screws. Your wisdom teeth aren't in the way of that, by the way. The reason why I bring that up is there's a little scar in your face to put those screws in. Not two scars, but there would be one scar. To put these screws in, your mouth doesn't stretch enough, so I need to put that in there. So I generally say it's a maybe that I put that screw in, but given the amount of movement and where your nerve needs space, I think it's a probably. So
That's fine.
bone graft will be here. This will be cadaver bone, again, mixed with your bone. And that allows it to help with healing. Jaw joint opening trouble generally are these tendons. These big fins are irritated by us operating around them. And so mouth opening that Andrea talked to you about is typically because of this tendon. On occasion, it's the joint, but your joints are solid. I don't know if that would be much trouble there. I don't know, questions about lower jaw that I can answer?
You were mentioning like a genio advancement as well. Is that something that is kind of off the table, or you don't think is a fit for the plan, or what?
Um, so
Not
yeah,
that
so
I have a preference. I was just curious because you mentioned it in the
yeah, so chin work. So chin work, there's kind of twofold options. One of those is doing a sliding genio. Where your chin is, the tubercles are a little high. So getting the tubercles with the chin, I think is not a reasonable option.
that makes sense.
So if we do genio, it's going to be more from a aesthetic standpoint.
Okay.
And I mean,
But but
honestly,
we're
it's
already
going to,
advancing and rotating. So
yeah, you're
there's
already getting 15 millimeters out of it. And I mean, the chin would be to shorten and advance it, but it'd be shortening it by like 2 millimeters and advancing it by the same. And is it really worthwhile? Um, in this magnitude of advancement in the 15 millimeter category of people, advancing the tubercle the extra distance, I don't think that's necessary, actually. I don't know if that's true, but I don't know. It's a I think we're already moving it far enough because the tubercle advancement, which it would still be a genioplasty like we just talked about, except this tubercle would be cut from below. So it's a bit of a trapezoidal cut. And what happens is this chin is then replaced. So in its forward position or in impacted position, so forward and up a little bit. But instead of the tubercle being on the back side of the chin, it would be on the front side of the chin. I know that sounds strange, but the tubercle advancement in your situation, I think you're already getting enough. So I don't think that's necessary. So, and you could always, not that I want you to go through any more surgery. I think we're already advancing things enough that that's not necessary. And if there's still some residual apnea or something like that, we could always talk about chin down the road. Um, I think that complicates recovery a little bit. So on the viewpoint of you getting married in December, I would be biased away from the chin work a little bit, unless you wanted aesthetic chin, in which case we can do that. I think advancing the tubercle with it, um, people talk in a weird way, and I don't really know for how long a time. Like it just feels like they feel like their tongue's pulled forward for a period of time. And with the short timeline on the wedding, I would favor shelving that if that was okay. Yeah, I do have it drawn up. So as a alternative plan here, I've quite a few alternative plans, but this was to introduce the idea of the magnitude of movement and just talk about what it looks like with one piece look forward and all that sort of thing. So were you biased towards chin? Were you thinking chin?
No,
Okay.
no, and that all makes sense that what you're saying. It sounds like it's already, again, maybe it's normal or mildly aggressive, but like with if we elect for a 7 degree or whatever counterclockwise plus that advancement, that is a lot compared to what I've sort of encountered over the years with patients. So it's on the higher side, right?
Yeah.
Already.
Yeah. I mean, if
Yeah.
your chin's already moving 15 or 16, do we need it to be 25 or 26? Because I mean, it would move another centimeter on the tubercle. And I just think that's a little bit overkill sometimes.
And we can do it later anyways, right?
Exactly. Yep. Yep.
Yeah.
Upper jaw surgery. So upper jaw surgery, this is one piece, by the way. So I have widening plan for you, but right now I just have it in one piece. Your one piece plan is possible that you end up with the splint, by the way. So
So what's that mean in layman's terms? I understand kind of what a splint. Are you saying like sticking a retainer in to stabilize things, kind of thing?
stabilize the back of the teeth. So upper jaw surgery, as it moves in one segment like this white piece, its moving is one, but this front area is still healing. So this widening business is still healing. Radiographically, it looks like it. Uh, I have the backup plan that if it isn't 100% bone healed, that I can manage that. And that management strategy is by putting a splint in. So a splint lives on the backside of your teeth. It's a horseshoe that lives on the roof of your mouth. It's basically to stabilize the transverse. So to let's say the upper jaw surgery happens and the midline from the expansion isn't completely solid. And so if there's some play in the segments, I don't want that. And so I will put the splint in at the time, and then I'll put bone graft to help that area heal. So I'll have that as a backup, but that would be the only scenario in this area, in this plan, where you would wake up with something on the backside of your teeth. So most likely that isn't the case. With upper jaw surgery, there's this incision underneath your lip. So lower jaw, I didn't mention it. There's these two incisions on your cheek. Upper jaw is underneath your lip. So it's right underneath the nose. The nose changes happen because of where we're operating, right? And so when it comes to upper jaw, there'll be plates. There'll be 4 plates and 16 screws that hold the upper jaw in place. Might be 18 screws. Don't anyway. It's to help it hold in place. If this is mobile, I will put a screw across the top here. So I guess formally 19 is possible, but sorry to get in the weeds. The plates and screws do an okay job of holding things in place, but they don't do a perfect job. So that's why I want to add more things to it. So your upper jaw expansion. So even though you're moving forward 11 because of the counterclockwise rotation, there's less of a step here, but there still is a step. And this step will not heal with bone unless I put something between it. So I need to put bone in there. Again, it's partially recycled from this area, but it's also cadaver bone. Cadaver bone's human bone, doesn't have cells in it. It allows the bone to heal in that area. So
I see. So you're saying you're moving the maxilla forward, so we're changing kind of this, and you're going to connect them, sort of, right?
exactly. Yeah, so it's less of a step. It tends to be a little bit more of a ramp in real life. But just like down here at the Dalpont, even though we're moving the teeth a certain amount, the bones tend to be a little bit less than what you would expect. So generally, too much of a step here causes your face to be too full, but your step isn't very big at all.
Okay.
The nose, so those little arteries I was telling you about that can cause that crazy nosebleed. All right, so as we look inside your nose, it's kind of a weird view, but this bone, this is a palatine bone. The artery and nerve that live within that are right in that location. And so as you see, as the jaw rotates and comes forward, that artery will be under tension, right? And it's that where the injury comes into play. Sometimes they're injured during surgery, and so the same is true on this left side, same location. If you watch it, kind of see how it moves. And I just ligate the arteries in that situation. The trouble with that is it increases the risk of tooth injury. So these front teeth, typically these front four teeth, are the ones at risk with not getting enough blood from upper jaw surgery. And so if you think about this like a stream, upper jaw surgery, the blood comes from the back of comes from the roof of the mouth, it comes from the throat, and from those arteries we were just talking about. So it all comes this way. And so the end of the stream is these front teeth. And so if we don't get enough blood going to them, they can have an ischemic injury. They turn purple or gray. I've seen two patients over the years have multiple teeth change color. But the most common thing is just one tooth changes. But unfortunately, it's one of those front teeth. So that's why I keep those arteries. If I take those down, your chance of that trouble increases dramatically. So the goal is to keep those arteries intact. So sorry about the risk of nosebleed, but I think it's not a high risk thing in relation to the teeth issue. Because the teeth issue, you generally need a root canal or a veneer or something like that, which your teeth have done well thus far. So I'd rather not cause trouble with it. Upper jaw numbness on the lip is because of these nerves, these holes in the skeleton. Just like the lower jaw, there's a nerve that runs inside bone and exits bone, gives feeling to the lip. That nerve comes out here. So that thing isn't injured at all. I just find it so I can put hardware around it. So your lip numbness actually gets better really quick, much quicker than lower lip numbness. But gum numbness is the one that sticks around. Gum, particularly in the front of your teeth, are quite numb. A lot of people have numbness right behind their front teeth after this sort of thing. So I don't think that's a huge risk afterwards. I think nose is the only other thing to talk about. So generally speaking, rotation of the tip up by doing the subnasal osteotomy minimizes that dramatically. There's an Ayler cinch. Ayler cinch is a permanent stitch that helps minimize base of nose widening. It tends to widen by a few millimeters even with that. If I don't put it in, you'll gain like 5 or 6 millimeters. It's pretty dramatic. So you won't be able to talk me out of that. Probably the main variable that comes up in terms of things during upper jaw surgery are if turbinates are in the way. Turbinates, I'm of the opinion of leaving them. But there are times, this is you in x-ray form, by the way, so you can kind of see how that black line, how small it is, right? Like how much space you have to breathe in your nose. And so while the plan is that we are only creating more space in the nose, if the turbinates are different size during the time, there's a tube in your nose, those sort of things. But if the turbinates are bumping into the upper jaw, I will reduce them. I tend to just reduce the bottom part of them, by the way. So the whole thing isn't removed. It's just that I reduce the bottom 3-4 millimeters of them. So that's a maybe. That does come up with upper jaw surgery. So yes, so what we've been talking about is 11, that 7-degree counterclockwise. Brown lower jaw is where you're at now, and you can kind of see the planned new position of the lower jaw. So it's a bit wider. The amount of advancement, I'd expect you to see a good impact in terms of breathing. So I think you're in good shape on this amount.
Yeah, I had a small question there. When you looked at my CBCT, what one metric that I understand is pretty predictive of sleep disorder breathing severity is minimum cross-sectional area. Is that true? Kinda depends how accurate the scan is, maybe.
Well, so like Schendel's normative data on orthodontic, have you seen that one? Steve Schendel, did jaw surgery for a while. He's named that I think he's retired now, but he worked with an orthodontist. I think it was Bay Area, somewhere in California, and they looked at what the norm of airway cross-sectional area is, and two standard deviations included zero, which obviously people don't have a zero cross-sectional area because they can't breathe in that scenario. So in terms of measuring that, I don't actually tend to measure that. I go based off of how bad your sleep apnea is. Actually, and I haven't seen your sleep study. I know we're kind of like jumping around a little bit. What was your sleep study? What did it show, by the way?
Um, I've had a variety of them, but the latest was it got rescored, and I had about an RDI of 17.
Oh, okay. Yeah, so more moderate kind of viewpoint. I tend to pull people up on different software to visualize their airway. So I'll pull that up. You're at the soft palate's kind of your narrow point.
So the maxillary advancement's the favorable component, and some is that fair?
The soft palate. Yeah, I mean, maxilla does that. Also tongue position, like advancing the tongue tends to cause a soft palate if your tongue lives at the roof of your mouth. So um I think the upper jaw moving forward 11. I mean, my other plan's 13 actually. That'd probably scare you out of doing it.
No,
But
I'm open to.
I also have
uh,
widening.
If I was your son, which one would you go with?
I like this plan because it kind of keeps you looking normal, by the way. It is a good so this is 13 and Genio. So this is kind of the most advanced plan, like as far as moving things forward. Um, so I'll tell you, these numbers, I tend to drift these up a little bit higher in people who have sleep apnea. I think you start looking full in the mid face once the top number is about 90 or 92. So you're still shy of that. It's just that I worry a little bit as an adult that you'll maybe not recognize yourself as much with 13 millimeters of advancement. I will correct this for the occlusal plane change that we changed on the other one, by the way. So we're looking at apples to apples. And so no chin. Um, Two, I think you're two. Um, um, so the magnitude of movement still is it's just not it's still not too far, but I think we're trending in the too far. I think they were compromising aesthetics on this plan. I worry about the aesthetic part. So my kids, I think I like them the way they look now. So turning them into different people, I think is a concern. And so I think at a 13 millimeter movement, I worry about that a little bit more with you.
This may
Uh,
sound crazy, but is this something that later on, let's say, could be changed, or is it best to kind of only do one double jaw surgery ever?
oh, it's best to do one
Yeah.
for sure. Yeah, like coming back and redoing it. Also, we'd want to redo it to a significant degree. So coming back and moving you like 2 millimeters is like, we wouldn't do that. But if you remember, the error bar again is if we plan 11, 9 is possible. If we plan 13, 11 is possible, right? So taking into account that sort of thing is the situation. You have more yeah, I guess more moderate sleep apnea, but on the lower end of that. So I think generally with severe sleep apnea, we shoot for about a centimeter threshold. So we're hitting it with the other plan. That's why I think that's probably a good one. So
So you're
uh, to answer the question on my son, I'd probably do the 11 millimeter advancement. I think that's reasonable. This is you, by the way, in 3D land. You've seen this version of you.
yes.
This
So
is your
that's what
airway.
I was kind of curious if you have any thoughts. What is your or can we even say, is it too complex because of what contributes and endotypes and et cetera, or can you look at this and go, okay, like this looks like a really obvious, this guy's going to benefit.
Well, yeah. So, with you awake upright and your tongue in a good position, um, all that may not be true when you're asleep. It's probably not true when you're asleep. So, this is as good as your airway is going to be. Does that make
Makes
sense? So,
totally, yeah.
while this doesn't diagnose sleep apnea, I think once you get a small enough area with your tongue in a good position, your head position, like you're not overly flexed in your head position, because there's some things that bias this, right? Like where you're at in the breathing
Right,
cycle.
right, right, yeah.
Um,
I
so
re
once you get to like a critical value of size back here, it's easier to collapse, right? And so the idea of measuring it, if everything else is equal, I mean, I it's been a while. That Schindel paper is old. I feel like it was 80 or 90 was the cross-sectional area that put you at a high risk for having sleep apnea. But you're right around that. You're like 100. So I don't feel good about quoting the specific number, but there
and
is a threshold that puts you at a higher rate.
I'm assuming too, like if in the normative data, the bigger you are as a person, that threshold would also probably be bigger. Is that not true?
Yeah,
Like,
like relating it to the human is I don't think they were able to do that, like based off of like, size of person, BMI, surface area, those sort of things. So um I think looking at you in 3D airway, doing everything we can to increase space is good. So planning version of you, I think um I wouldn't do less than 11. And I think the little bit extra counterclockwise rotation is good uh, to freak you out. I don't like this plan, but I'll show you. This is what I was thinking when I met you first in person. I thought you needed widening. Um, so this is the same forward movement we're talking about, but from the front, it broadens things.
sorry, what's difference? The difference here, you're widening the maxilla in a three piece?
Widening both arches.
Oh, both arches.
Yeah, so widening both upper and lower. This is a longer recovery. I think with your wedding coming up, I think this is a bit overkill. This is usually I apply this to people who can't tolerate a big enough movement forward. Like if I can't only move them like 6 or 7, I tend to widen them. It's just your arches allow for that, and so this shows two-piece upper and then midline lower. I think this is where the trend is going to go with it. It's just it complicates it in terms of recovery. Your wedding coming up. I know you told me you're going to recover like a champ and it's going to be a straightforward process. It's just like that example, that lady I showed you in clinic, she had widening. She had chin and widening work. And so like hanging under the residual swelling.
Do you f- do, do you feel like let's just imagine hypothetically the wedding didn't exist. Do you feel like we're leaving something on the table here because of it? Like we're compromising? Like would you or let's just say that yeah, there was no wedding. Does that make that plan you just showed me more of a favorable, or do you think it's still better to kind of go with this one?
Well, because it's I'll be honest, I don't know. I talk to people about it. Your anatomy allows for widening. You have a narrow arch form in the mandible. Your lower arch is narrow. I wouldn't hate it if your upper arch is a little bit more wide as well. Those things in terms of transverse, the relationship to the airway is something that is is evolving, I would say, our understanding of that. So last 10 years, a lot of transverse discussion has been going on. That wasn't as much of a thing 20 years ago. I mean, it existed somewhat, but people seem very interested in the transverse. We're one of the few centers that actually offer the widening part of things. I'm kind of in the middle of figuring out who's the right people to do that on. It's just that it's a complicated operation independent of the widening. And so if you add widening to it, there does run a risk of overcomplicating things, right? Like making the finishing of the braces with Invisalign a little bit more difficult, or the healing process a little bit more difficult. And to offset the added complexity and the variable, the uncertainty that comes up, I would want it to be beneficial, right? Like I would want it to really like make a big impact. And I'm not sure if you're in that category. So I'm trying to based off your arch forms is why I worked it up. So you have narrow arch forms is why I have that as a plan. But I don't know. I started widening people. I think it was I had a Boeing engineer talk me into it. It's a funny story, but he was like, "Why don't you just widen things?" I'm like, yeah, why don't I widen things? Because I do it for other reasons. But from the sleep apnea side of things, it was probably like 26, 17, so maybe like 8 years ago. That seems about right. And over time, it seems like it's a good intervention. It's just in your situation, you're getting a good advancement already. And so I think that I the voice, whatever you hear different voices, the angel and the demon or whatever, you see the two sides of the argument. The side of the argument of, hey, this is already complicated enough, let's just get you through that, heal up, get you on with life, breathing better, versus the side which is, well, I mean, we could probably do a couple more things to help you out, right? I think the single piece upper and lower is enough. You've already been through expansion of the upper jaw, so you've already achieved a little bit of that. And so um, I I would be of the opinion that if revision came up, like you still had some residual trouble generally is nose breathing, by the way. If it's not that, then it's base of tongue. But let's say we got to the point of talking about revision, I would float the idea of widening in that world. So,
If it's worth anything, I don't know what this context means to you, but after doing my maxillary expansion, I wanted to see how I slept, obviously. And with nothing, it wasn't great. But then I stuck an Alaxo stent in, and I sprayed Afrin in the other side, and I more or less slept perfectly. So I think I'm very borderline, if that makes sense.
okay.
So I
Yeah,
think all of this should be enough. Does that mean
definitely.
anything to you, or is it kind of just
Yeah, yeah,
rant?
for sure. Yeah, because I mean,
I don't even snore too. I recorded. It's like a very light kind of snore in during some periods of the night. It's uh it's very borderline, it feels like. But I don't know.
yeah, so um I think this is a good intervention then. So I think in terms of doing the right amount of surgery for the problem, this seems like it.
Oh, and sorry, that RDI quoted you, that was pre-maxillary expansion.
Got it.
I haven't done
Yeah.
a sleep study since then.
So, I mean, centimeter, 15, 16 millimeters of your chin. It's about how far you can slide your chin forward. So like as you maximally bring it forward, sometimes you get a little bit more than that. But from that perspective, we're creating more space for you to breathe. So I would expect there to be a good airway response in terms of this game plan. So doing upper and lower, keeping it to one piece, not doing chin surgery. Um, you're doing the 11 millimeter advancement, 7. Is that what we decided on? About 7, 6.5, something like that, counterclockwise, and then a few millimeter impaction. I like the plan. Yeah. Let's see, what else could I answer about this? I think I covered all the main points that I want to talk to you about. There'll be some posts inside your mouth. Andrea tells you about those. Generally, there's 4. Sometimes there's 6 if we want to get fancy. Teeth contact looks good. Can't wear your Invisalign trays afterwards. Maybe wisdom teeth. So,
How
okay.
long can I not wear those trays?
Uh, you'll see. You won't really feel like wearing them afterwards. So most
Oh,
people
I
stay
guess I
out.
have to get those posts out first. So 6 weeks at least, right? Something like that.
Yeah. So most people it's a couple months.
Um, am I thinking correctly that when you advance the maxilla, you obviously advance that arch, and the turbinates will naturally be in a part of the arch that's wider afterwards, so you would expect nasal breathing benefits in that context? Or
Um,
or am I not making much sense?
yeah. So I think the length of the nasal cavity is a little bit longer because the upper jaw is moving forward. Um, which I generally think of it as a negative thing. Turbinates generally fill up the gap they have, and so um, the trouble is not taking away space. The plan is the posterior nasal spine, so the back part of the upper jaw is moving down 2 millimeters. and the front's moving up 4. So the front's where I'm harvesting it. It's really like the transition between those, like the middle teeter-totter area is where the possibility of removing the turbinate comes into play. Not removing the turbinate, reducing the bottom part of the turbinate, sorry. And so I think generally it's a little bit more complicated because the transverse is correct as you're saying. So as you're bringing it forward, there's a wider part in back that's moving forward. Um, but from like an AP, there tends to be a little bit of complexity there.
Okay. Should I expect to breathe better through my nose afterwards? Is that
Yeah. Yeah.
common, mixed bag? And if so, why is that happening?
Yeah, so right afterwards, it is because of all the work that we've done inside your nose that right after you're breathing better. It's up and down because of that congestion. So as blood clots take over in your sinus and they kind of like take over in the nose, that tends to cause things to be clogged up. There's also swelling, like the Afrin, like helps reduce the swelling a little bit. Um, so we want breathing to be better altogether. It's just it's a bit up and down in the recovery process.
I guess what I'm not understanding is just like in the long term, in a year from now, why would I be able to breathe better through my nose? Is the kind of simple question I'm
Because
asking.
the floor of the nose is like the space in the room is more because the floor's gone down. You're like
Okay, and that's from the shaving thing, not advancement,
um
or both, kind of.
it is from the aggregate movement of the upper jaw and the shaving in front.
Okay, that makes sense. It's just a random question, not really in
Yeah,
the
no, it's kind of
decision making process.
it's a weird concept. Like the whatever it is, the haunted house in Disneyland, the haunted mansion. When you're standing there and the ceiling's moving away from you, it's like that. But I feel like the floor's moving differently. I don't know if you do. You know what I'm talking about? Have you been to Disneyland?
Yeah,
No.
I know what you're talking about. Yeah, I
Okay.
did. I read a I don't I guess I asked this because I read a paper once by Dr. Casey Lee in 2010, and
Yeah.
it talked about like variables that predict success on an aggregate, and one of them seemed to be maxillary advancement, but I just don't understand what the mechanism is there. I guess I'm trying to ask that.
Yeah. Well, I mean
Is it the tongue
uh
gets more
the
room?
the best meta-analysis on that, or at least what I think is the best meta-analysis, is Capel's paper in 2010 in Sleep. And they did, the whole multivariate analysis on success data. That's where that 8643 comes from in people with severe sleep apnea. Um, they didn't find that mandible advancement had a relation to success. They found maxillary advancement.
That's what I thought. So I'm not crazy, right? This is
Yeah,
right.
no, that's out there. It's interesting because most people think I'm talking about the chin in terms of advancement, but what's weird is it's measured off the central incisor. And so it's like, because they aren't talking about maxillary advancement, they're talking about central incisor advancement because what's happening in different parts of the maxilla is different. And I don't know, I think um I generally think why that's the case is um maxillary expansion on bigger movements. Um, it's that the face allows for that sort of thing. Like you have the space to move it, right? So if there's scar tissue that doesn't allow the maxilla to advance because you had a U triple P, so you're only moving like 6-7 millimeters, then there's other factors, right? Like it isn't um the amount of maxillary movement that you can pull off, right? Like what can actually be done by the surgeon has a limit to it. And so, being Um, MMA for a long time was really just pull the maxilla as far forward as you can. And if you can't pull it very far forward, it stands to reason that the airway is not going to expand as much. So I think it's more simple carpentry than it is fancy flow dynamics. I could be wrong on that, but I perceive it to be that. So
Interesting.
I wish I could complicate that further, but that's how I wrap it around in my head.
Okay, that makes sense. Yeah, I think that's pretty much it. I guess final question would be like, I think you said 11 and then the other plan was 13. What do
Yeah.
you, where does your mind go if I say, well, what about in the middle of that?
Oh yeah, that's fine.
Like a 12?
Yeah, that's fine. I don't mind that at all.
Or do you think
Yeah, I'm
that's,
I'm never gonna argue about a millimeter here or there in any of this stuff. Yeah, I don't mind at all.
do you think it's
Yeah.
worth the,
The scoot?
yeah, yeah, I guess I'm asking, does that change anything for you? Like, am I gonna look any different? Is there more risk? Is it kind of not worth it? Is it threshold area?
Millimeter difference doesn't matter. Yeah, like decision making should be more on like the 2-4 millimeter jumps. 1 millimeter doesn't matter. It's just shading a little bit on either side. And so where you're at, I think that's just fine.
So like a
Yeah.
12 millimeter on the maxilla.
Yep.
Yeah, okay. So
Yeah.
in summary, am I understanding the movements correctly? You're saying pognia. I never know how to say this. What's it called? Pognia?
Pogonion.
Pogonion.
Yeah.
So Pogonion 15, 18, maxilla is like 12 plus air bars for both, and then counterclockwise something like 7.
Yeah. So the as I mess with these things, it throws different things off. So let me adjust the counterclockwise 4-7. So yeah, so you're right at 12. Don't look at the fractional bits. And then 3.5 up. Um, and then Pagonion's about 16.5, 17, right in that range. This leaves you still some room for your orthodontist to work. Your contact, by the way, is in the middle teeth, so your middle teeth touch. The back teeth don't touch completely. It's largely in the middle teeth. Um, and that's just because there's a little bit more braces to do. So they'll work on that.
Okay.
Yeah. But on the moves, I think you got it right.
Okay. And there's error in that counterclockwise too, or is that an error-free movement?
Uh, there's air in it.
Yeah. Okay.
Yeah.
I guess I don't really have any other questions.
Okay.
I think that's it.
Great. Yeah, no, I like playing. It's a good one. We'll see you on the later on this week. Andrew will get those prescriptions to the pharmacy over here. I assume that's what you guys worked out. And then on the day you'll meet our anesthesiologist. Max is a good guy. You'll like to talk.